This is the Born Ludwig Year 1 podcast.
Hello everyone, today we have a special guest. It's Roxana Petcu from Romania. I came to the idea to invite her because we had, I think a week ago, our topic was TMJ. And she was very active, and this is one of her special interests besides being an orthodontist. So I thought, let's talk a bit about herself, being a mother, about being an orthodontist and private practitioner and TMJ. So, hello, thanks for joining us, Roxana.
Hello, Björn. Thank you so much for your invitation. It's such a pleasure to be here.
So we decided within the last few podcasts to first look a bit at the person behind the orthodontist. So my first question is, where did you grow up and what kind of child were you?
Well, I'm from Romania and I was born and raised in Timișoara. That's in the most western part of Romania. It's very close to Budapest, actually. I was raised actually speaking German. So I learned German as a mother language. I did everything in German. I think I was a very disciplined child, very hardworking. I learned a lot. But also I had, I think, my rebel years, like all children do. And then I studied. I did my dentistry, university and residency, everything in Timișoara, and I'm still here and I'm enjoying it very much.
And why dentistry and later why orthodontics? How did that happen?
Yeah. So actually in my family, all the women, the line of women, my mother and my grandmother are doctors. Well, my grandmother was a doctor. I was very inspired by her growing up. She was born in a very small village without any financial means, and some way she learned and made herself up to Timișoara, where I think she struggled for 3 years to get into medical university, because in the 50s, women, and especially in Romania, they were not very allowed into university studying. So she was very determined, and she became one of my role models in life. So I knew from the beginning that I wanted to step into those footsteps and do medicine. And why or dentistry? Actually, I did dentistry just to go to orthodontics. I knew right away that I wanted to be an orthodontist. Actually, because I had braces. I had braces in high school. I had very crooked teeth, ectopic canines and everything. And it's very interesting. I did not find a picture with me growing up with me smiling, because I was very conscious of my smile. So when I did orthodontics, and of course I had to extract some teeth to have a space for all of them. And I saw what changed in myself, and that I was able to smile again, and the self-esteem that can grow from such a treatment. I told myself right away, this is the thing that I want to do in life. So I just got to dentistry, straight away to orthodontics, and this is it.
Cool. I mean, you are still young, but I mean, you are a bit in business a while already. So if you look at the young Roxana at the beginning of your orthodontic career, what did change? What do people see today that looks easy maybe for you, but was actually very difficult, being the young Roxana until now as an orthodontist?
You mean right from
was it more
the beginning?
Like the business side from the beginning, that it was difficult to establish enough patients to run your business, or was it more the technical part that you felt it was difficult to insert some tabs or understand mechanics? So what changed? I mean, can both from the financial aspects to surviving, and also maybe as a clinician?
This is a very complex question.
Just focus on one part.
Yes. So actually, I think the most difficult part, especially for a woman in the beginning. So I do orthodontics now for more than 15 years, for 16 years to be precise. And in the beginning, the most difficult part, of course, actually, besides trusting yourself, because when you get out of when you get out of school, basically you're like a child. you don't know much, and you have to get out there and to do stuff, to learn stuff, to get to know people who inspire you and where you can learn a lot. Also to make mistakes. Unfortunately, this is something we also learn by mistakes. But also what is very difficult in the beginning, especially for a woman, patients don't trust you.
That's true.
And besides trusting yourself, you also need to make the patient trust yourself. And this is a very interesting and difficult moment. And self-trust comes through time. Once you start finishing your patients, and then you also start to see the recalls on your patients, and you see they are doing fine. And actually this takes a lot of years. So 2 or 3 years of orthodontic treatment, and then you need also the years for the recall. And only after a while of those years, you can say, okay, so I did good, and I have proof that I did good because the patients are doing fine. And then it's very progressive, and learning to trust yourself in our domain, I think it takes up a lot of time.
It's very good because I think there is a gender difference in that perspective. You know, I see a lot of male, and I can talk for myself. When I finished the postgraduate studies, I did not feel like a child. I felt like I'm super. I know it all, amazing. Yeah. And when I talk with women, they're more like, oh, I'm defensive. I have to learn to trust myself. And which is way more realistic than we boys are. And then the other thing is, we had it in our office. We have it with the postgraduate students. As a young woman, you look younger. You have to really fight your way. Then patients will trust you. And I feel it's heartbreaking. We just had it this morning as well in the office that the patient requested, we want to see Björn. Yeah. And they think I'm more competent. And at times it's not true because I'm even more distracted. And I see it, there is a gender difference. And I feel this is at times heartbreaking. I agree with you. Yeah, you have to fight much more. And women are way more realistic than men are. Yeah, that is very nice.
Yes. And a funny story, we recently had a male resident in the clinic. And of course, he's young, but he's a male. And so a patient needed to get a TED inserted, and the patient asked the assistant, so does the male doctor insert it? Because my colleague, my female doctor, who's working with me since 6 years, she was there ready to insert it. But the patient still asked if the male doctor was going to insert it. And the male doctor was just a resident, just looking there. And I thought, wow, interesting.
It happens in our office almost daily. Then we see the difference. And as younger you are, as more you feel that, and at least as younger you appear.
Yes. And also women have to learn to be more firm. I think this is the word, because they are oftentimes very nice, very soft speaking, maybe a little bit too nice. And maybe we need to learn more to set solid boundaries.
Yeah. That's true. Yeah. But that's good because I think it's good for our profession. It's hard. It's a hard path, but then you get clearer. Yeah. I see it with men, an example, they gamble at times and they want to be the king of the moment. And this positive feedback gives the wrong self-reflection. And as you have to stay firm, document everything, do it as precise as possible, I think you get a better orthodontist, but I think it's a harder way. But we see this.
Yes.
You became a mother later.
Yes.
How did it change? I mean, less yourself personally, but more professionally. Did it change how you treat your office? How did you integrate it? Because in our profession, we have more and more female, which is wonderful. And I hope many have the chance to get a mother. But how did it change you?
Well, actually, I have 2 children. I have a daughter who's 12 and a half, and I have a boy who's 1 and a half. So there is a big gap between them. And it is difficult to integrate everything. My daughter is big. So in the past years, before my son appeared, I could focus a little bit more on work. But now that my son is here and my family is my priority, so my number one priority, and the most important part is that they are healthy and safe and we are all good, because when we are good as a family, everything falls into place. So they are my number one priority. The second, since my son is born, I cut down on the hours that I'm in the practice. I'm very fortunate because I have a very, very good team that is working with me, and I'm working with them for many years, for about 6 years now. And while I was away, I still talked to them. So every day they sent me the pictures. We are very disciplined. So we are a group of women. We are only women here. We are very disciplined, and we document everything very good. We plan everything. And although I was not physically here in the clinic, I always was, whenever I had the time, just to look on the phone or on the laptop to see the pictures, to see how the patients are doing. And this allowed me to be less physical here in the clinic, but also to see everything what was happening with the patients, and to be able to stay home. And from my teaching, I did 1 year break. And then once the baby was a little bigger and I could get away, I started to have my courses. But then in the break, I would go back home and feed him and then get back. So, well.
What I often hear, and I felt the same, I have 4 children, but they are all grown up. The youngest is 20. And I often felt some guilt, when I started traveling, or even I tried to bring them each morning to school and I went home at lunch break. But still, depending on their character, they are all 4 different. I felt guilt when I was not with them. And I hear that even more from females, that they say, I'm have these kind of conflict. I'm passionate for my work,
Yes,
but my family, for sure, by heart is my priority. So at times it's feels squeezed between it, or I have to make a certain decision. Is that something you feel at days and weeks, or you can balance it well?
Well, it's very different now with my daughter. So I told you she's 12 and a half. And when she was born, I was still in my early years where I wanted to prove myself, to prove to the patient, to prove to the peers that I'm a good orthodontist, I'm a good professional. And I also was a young mother. So I worked a lot with her while she was young, and I felt a lot of this guilt. Not being full-time with her, because I also wanted, again, to prove myself and to work and to gain experience. And I worked a lot. And then I got to a point where I realized it's too much.
Too much.
It's really too much. And actually I think it was in the time of COVID when I said, okay, stop, it's enough. I have to change a lot of things, not working that much, prioritizing the people I love and spending more time with them. So now with my son, I'm doing it very different. I just want to enjoy and to spend as much time with them as possible. But in the same time, I can do this because more years have passed and I'm more confident in my practice, in myself. We have established our patients. So it is difficult to be a mother and to be in the young years, in the early years of orthodontics. It's much easier once you grow as a professional and once you trust yourself. Yeah. So I don't know which one is better, but I feel more at peace now. Yeah, this is what I can say.
Yeah, I can absolutely understand you. My oldest daughter is born when I was 23 or 24. Everything happened simultaneous, building up the office, the family, and I always was like in between. If I could now, with the knowledge I have, I would have gotten kids later. So when I would have been a bit more experienced, more stable and more calm. And that brings me to the next question. None of my children goes into dentistry or orthodontics because they said, no, that it's not a good profession. You always looked a bit stressed and in fear about financial things or whatever. And they all slipped into different professions. What do you hope your children will one day understand about your career, your professional career? What they would say, like, mother, we looked at her on stage, or she was loved by her team, or anything specific you would say, that would touch me if my kids would remember that about my career?
Very good question. Actually, what I would like my children to say about me is that I was kind, that I am kind. And I think kindness is the most important thing for us. Of course, we are good professions, and of course, we want to be good at our job, but to be kind, I think this is the strongest point. And I do what I do with passion and with kindness. And this is what I want for my children. Whatever they choose to do, I don't want them to go into dentistry or into orthodontics if they don't want to. I want them to go do something they are passionate about and that they are kind to the others around them. I think those are the most important.
I can agree. I think that is something you should strive for, because when I look at myself, I was traveling the world and the kids do not care. They care what I did here, and they said you give more than you take in my close environment, and that is, I think, something all the travels or articles was, at least for my kids. In the audience, you attended to a lot of courses. Remember that, the FACE program, and that you went from TADS to the joint and whatever. But then at a certain point, you started teaching, and that's quite interesting. When did you realize you want to share your knowledge, and what did you make comfortable to start speaking? Because now you are a renowned speaker at different stages, you give your own course. How did that transition happen?
So again, it was very gradually. And actually, the way I started teaching, so yes, I started with, let's say, it's very linked to my professional way into what I learned. So actually, what I can say about me is that for the first 4 years, I did not have my own clinic. So I just later had my own clinic. I worked at an office, at a very good orthodontic office in Timișoara, that did mostly, I think 80% just Invisalign and Incognito. And it was right after I finished dentistry. And for me to start working with aligners and Incognito at such an early age, it was fascinating, but it was also like cheating, because I skipped over classical biomechanics and everything else. In the same time, I learned a lot of tricks with aligners and segmental orthodontics and TEDs and how to combine them. But then at a certain point, I just realized, you know what? I feel like I'm cheating. I have to get back and to learn more about the classical biomechanics. But also I felt that there was this big part of the TMJ and the occlusion that I didn't understand. I didn't fully understand. It was like the black hole of orthodontics.
Yeah.
So I said, okay, I'm learning a lot here, but I have to make a change. And I went away and I got into very good interdisciplinary teams that were having very, very good prosthodontics. And they really knew what they were doing regarding the TMJ and regarding the occlusion. So I made a shift, and then I started to learn pretty much about prosthodontics and about occlusion.
Mm-hmm.
And a lot of what I know and what I teach today, I know from the prosthodontics program. And then while I were in those groups, I had this colleague, Dan Lazar. He's from Oradea. Maybe you know him. He's a very, very nice guy and a very good professional. And we've been working, I think, 8 years together. Now it's a little difficult because he's in another city, and for me to travel, it's not possible anymore. But for 8 years, we worked together and we had some amazing clinical cases. So he was teaching at the time, and he said, okay, let's do a program together. It was for dentists, so it wasn't for orthodontists, but it was a lot about the diagnostical part, the planning part, and of course, integrated in that was the occlusion and the TMJ. So I got to work a lot. I wasn't alone, and I had help doing this teaching part, but I enjoyed it so much, and I could really level with the participants because I could place myself in their spot and understand what they didn't understand, and basically we grew together. And then years later, I'm still talking about the TMJ and about the diagnostic, and I really love teaching. I really love working together with people, and actually this is it, learning together.
You selected a very difficult topic, the TMJ, as one of your main subject of teaching. I almost have to say I have an allergy against TMJ. I have a friend in Munich, Christian Sander. He has on his website, I love that, we are not treating TMJ patients. Don't ask for an appointment and don't send us some. I think that is very brave. And I think that is also shaped because in my generation, when we were trained, it was so much nonsense and guru style and non-supported things. But the answers you gave within the group are very much comforting to me and very realistic. So, and I like that. And I reflected on myself. So for sure you have a personal interest, but who shaped you, your opinion, your perspective on TMJ in your career? Who were your teachers and mentors? Just that we have your background.
Okay. So there are two worlds that were not before long very separate. So the orthodontic and the prosthodontic world. From the orthodontic part, I did the face course. And back then, I did it 10 years ago. Back then, they were basically just them who were talking about the TMJ. Now we have much more people interested and knowing about the topic. And then the other part was the prosthodontist. So I also had the chance to attend the Dawson courses, to hear the Frank Spear speaking, of course, read everything, the literature that was about occlusion and the TMJ. Jay Levy, if you know him, is very, very good on occlusion. So I was able to take bits and pieces from everyone and just to make something that I was easy to implement in the clinic, not very complicated, not with very much equipment. I don't think, and I'm not using that much equipment. I'm just doing the basic diagnosis and working with the classical splint that I'm modifying sometimes if the patient has pain, and that's it. So it's very simple and it's very easy to put in practice. And this is also what I'm talking in my courses about. So what I want, for example, the people that are coming to my courses to understand is to have a very good understanding of what is happening and to be able to diagnose and to see if it is a muscle disorder or an intracapsular disorder and how to approach this, and also to know the limits of what we can do and what we cannot do for the patient.
When we look back in the TMJ field, historically, it was very controversial and almost ideological. Yeah, that people that I'm that school and that this was like a religion.
Yes.
And now you are quite a while in that field. You said 10 years ago you looked at, you went to the face courses. What did you believe about TMJ 10 years ago that you no longer believe in today? Is that something which changed? I mean, through clinical experience, through like people, you were exposed to different people, you have seen different research.
I think
I give you an example.
Yes.
We were trained at Heidelberg. I studied university. We did like cis-centric relation. We took the mandible, we forced it as far back, like in the articulator that our dental technician had did. And for me, it was like the Bible. You had to do that, as more painful, the better. And then you do that. And for sure, it was kind of nonsense. It is something for me. Now I'm much more relaxed and I like to get the patient into a relaxed position. Is there something similar for you where you say this has changed within the last 10 years?
I think things got more clearer and more simpler. For example, 10 years ago, I would splint 70% of the patients and I wasn't able to tell you why. It was just because I was taught to. And now it's much more clear what do I need to obtain with the splint from the patient, because sometimes, for example, if it's an intracapsular disorder, sometimes you need to give a splint to the patient just for him to feel comfortable and to allow the patient's body to heal itself. If it's a very high activity muscle patient, so the patient that always clenches, the question is where is the first contact point? Where do you start your treatment from? So you give a certain splint, maybe an anterior deprogrammer for a certain period of time, for a shorter period of time, just to help the patient relax the muscle so that you are able to guide the mandible and to see the first contact point. So you have a much clearer understanding from where you have to start your treatment. But there are very separate things, the intracapsular disorder and the occlusal muscle disorder. So this is why I'm giving splints to my patient. I know it very clear now, and I'm not giving it to everybody. I think the number of splints that I'm using decreased through time because again, it's much more clearer now.
If do you think historically that dentistry blamed the bite a bit too much for TMJ problems?
Yes and no. So what again, 10 years ago, I would tell you occlusion and TMJ are 100% related. Nowadays, I can tell you there are so many problems that influence, that can create this TMD, and occlusion is not a part of that. It always is a question of, again, which is the weakest link in the system of the patient, because patients respond differently to occlusion, and maybe a bad occlusion affects more the periodontium of a certain patient than the TMD. And it depends very much on other factors. I see patients, also my patients who I have treated, they have a very good occlusion, they are stable, but in certain times of stress, if they're not sleeping, if they are very stressed or certain painful situations, they could have again this pain, this TMD activated. So I learned that I cannot control everything through occlusion or splints. Maybe I can improve the condition of the patient. Maybe I can stabilize a better occlusion, but this doesn't mean that that patient will be pain-free for all his life.
Very classic. We hear almost daily from our patients. It's like a clicking joint. My joint is clicking.
Yes.
And then in the worst case, you take an MRI and you have a mild finding, nothing special, but it's mild. So it's clicking. Then you have maybe anterior disc displacement with some repositioning, but no inflammation, nothing. So then you have a dilemma. It's clicking, you have a mild finding, but basically the patient has no problems, no pain, no nothing. And then what to do? Yeah, because you even documented something which is maybe not relevant, but maybe still relevant. So should we treat? Is that over treatment? Should we do nothing? I hear that question from especially young orthodontists a lot. They feel completely not confident and lost.
Yes. Yeah. I also get the question a lot. So what I can say and what I always tell the other people, if there is only a clicking, and yes, this is a sign of an anterior displaced disc with recaptioning, and the patient is pain-free. When you do the load testing, there is no pain on load testing. When you try to guide the mandible, there is no muscle resistance from the mandible. That patient is a green patient, so I color code my patient. That patient is a green patient, even if he has a click. So this means he is able to go into treatment, into orthodontic treatment or prosthodontic treatment or whatever, without the need of a splint. So just having a click without any other signs is not considered pathologic and should be treated with a splint. And also this is very important to tell the patients, even if you have to treat them with splints, if they have pain on loading, or you have to deprogram the muscles and they have a click, you have to tell them, the click will remain even after the splint, because we are not treating the clicking, we are not looking after recapturing the disc is out and it will remain that way, and it is not a sign that things are not working there.
Yeah. I had this morning a call with Manuel Nienkemper from Düsseldorf. A patient called us and she's from Düsseldorf and wanted to travel here. And I said, no. Look for either Benedikt Wilmes or Manuel Nienkemper. They are good. And Manuel had a phone call with her and she said, Björn, I think she's crazy. Would you mind if I not treat her? I see a lot of red flags. And the question is, what are the major, just give me 3 red flags where you say, no, it's not something I should start with treatment or diagnostic. I should maybe ask for help, refer to any other discipline, or maybe even refuse treatment. Do you have like 1, 2, or 3 red flags where you say, better not?
Yes, I have, and I will give you some examples.
Yeah.
But before this, I want to establish. So I use this color coding, the green flag, yellow flag, and red flag when I'm treating patients. And what this means, I gave you the example with the green flag. So green flag patient is the patient who is ready to undergo orthodontic treatment without the need of splint therapy before. yellow patient is the type of occlusal muscle disease, like Pete Dawson says. So with high muscle activity, with interferences, Bruxer, parafunction. So mostly you will need to deprogram those patients. And the red flag patient is the patient with intracapsular disorder, where you might find a medial pole issue, you might find an active erosion of the condyle, the disc is completely out, then you have the retrodiscal tissue in between the condyle and the fossa, and everything is, so the patient is in very much pain. There you have the red flag, meaning you have to stabilize the joint, mainly with a full cover splint, just to wait out to equilibrate it, just to wait up so that all the tissues in the articular capsule can heal. And only after you can go into treatment. So this is the color coding from the articular point of view. But there is also the color coding from an, let's say, emotional and psychological point of view. For example, I had several patients who were in high emotional distress. And when a patient is in a high emotional distress, in many situations, everything hurts. Come to me and they say the head hurts, the muscle hurts. Also, a lady told me recently she wasn't able to swallow properly, or she felt that she cannot see with an eye very good. So this for me is a very red flag from the psychological point of view. And I would not go into treatment with that patient until I see that I can relate to her, that she is emotional stable. Let's say this is the main part. So always also check this part, how emotional, and maybe you can use the same color coding for the emotional part of the patient. But now from the physical part, from the physical point of view, if a patient tells me that the pain is like a thunder and it's going into the whole face, maybe this is a neurological problem. Or maybe this has something to do with the trigeminal nerve. Or maybe a patient will tell me the ear, some kind of ear pain, ear problem. Maybe again, it's not our domain. So there are red flags from the physical point of view, and there are red flags from the psychological point of view.
Yeah, but it's good to have that color coding, and I like that you have one for the anatomy and then one for the psyche, and then you can check that and document it. That makes a lot of sense.
Yes.
We are almost at the end because we are a bit over time, but I have a few final questions. We started with you as a person and we end with you as a person. I mean, a private person, not a professional person. What are you proud of that would never appear in your CV? I mean,
My family.
Your family?
Absolutely, my family, my husband, my children, the love they have for me and I have for them.
But you can write that in your CV. That would be that would be wonderful. And what is Roxana when she is not an orthodontic teacher or mother? I mean, we talk now about your profession, then about your family. Do you have at least one hobby, or at the moment no time for a hobby?
Well, not very much time, but
I saw you playing
play the
good piano.
Yes. I actually started to play the piano in the pandemics. I never played it before, but of course I was very disciplined, and I had a teacher for just before my son was born. Each day I took an hour of lesson, and then I practice also myself. So whenever I have time and a little bit of time just for myself, I'm playing the piano.
Okay. Please complete that sentence. I wish I had known earlier that...
I think to trust myself.
To trust yourself. That's a good one. You started with that, and you end with that. And I think that's a good message. And I see here a gender difference. Normally, I don't see people as genders. When we talk with each other, I don't see you as a female, or I see you as a human. But I agree that was a wonderful perspective today, that when we enter the profession, when we face others, when we are on stage, when we are with patients, there's still a bit of difference. Yeah.
Yes, it is.
Final question. What do you hope people remember after meeting you, not only as an orthodontist, but as a person? If you go to a meeting or with your patients, you said with your children, kindness.
Yes, well, whenever I So professional wise, when I meet people, my aim is to be as honest as possible and to share with them everything, because normally when people go to conferences or to lectures, they see everything that is beautiful and everything that is perfect, and actually it is not. And I have a lot of cases that are not that perfect. I wish them to be, but they are not that perfect. I don't finish all my cases in class 1, and I try to be as transparent as possible, as you actually do, and you are one of the there are not many people like you that are that honest, and I hope people remember this, that it is normal to do mistakes, to learn, to ask for help. There are no doctors, no professionals whose cases are perfect, are all perfect. Yeah. And this is what I'm aiming for.
I think
just to normalize everything.
It's a huge misconception in dentistry and orthodontics. If you compare that to any other medical discipline, they don't have it. We are so trained in perfection. In prosthodontics, I remember at university, the preparation margins and everything. Yes. And if you are not perfect, it was already a mistake, and that's a huge burden. If any other doctor says there's a probability that you die, and then you die. I mean, I can show you some empathy, yes. Okay, but it's not my perfection that you survive or not. And I think that is a massive misconception we have in dentistry and orthodontics, that sure, we should always give our very best. That is our duty. But it's at times, and it's oftentimes impossible to finish how we planned.
Because we have so many limitations, so many biological limitations, and the patient also limits us. So we do our best, but it's far from perfect.
Final question, it just comes to my mind. Would you do it again? Would you get an orthodontist again?
Absolutely.
If you have all that family office teaching, it's you do it again.
Yes, 100%.
Good to hear.
Yes.
I would not do it again, but good to hear. I don't know, I would do something where I could be close to perfect, like manufacturing tables or chairs. You do your best, and then it's good. Thank you, Roxana. Thanks for taking the time today within your busy schedule, family and practice. And thank you.
Thank you very much.